All right. So, good morning, good afternoon, or good evening to all our attendees from around the world, and welcome to our webinar, Leading the Change for Advocacy and Humanitarian Crises. We are honored to welcome you to this webinar, which is organized in collaboration with the Miti's Zindagi Foundation, with the incredibly inspired participants and experts who will be joining me, who are not only passionate about advancing well-being of vulnerable communities, but are leading the change on the ground in the midst of crisis. My name is Sylvie Malouf, and I will be your moderator. And as the managing director and the co-founder of the National Diabetes Organization, DiaLeb, based out of Lebanon, we are well aware of the unique challenges that people living with diabetes and other non-communicable diseases face when they're trying to access and keep up with their medical regimens in times of crisis. We are living in very difficult times with protracted polycrises, from rising economic insecurity to forced migration due to climate or conflict. Climate events are becoming more frequent and more severe, and war and conflict more pronounced. Close to home, the Beirut port explosion of August 4th, 2020 led to the launch of our own program called Medication for All, and we were able to provide hundreds of survivors who had lost their livelihood and been forcibly displaced for their homes with life-saving diabetes medication. Further to that, there was financial crisis, lack of medical supplies, and then war. So we've been able to support as much as possible, but our efforts are minuscule compared to what is required. Globally, the world is witnessing unprecedented challenges. Millions are facing the dual burden of conflict, disaster, chronic health needs, and access to healthcare is becoming more and more difficult. For those living with chronic conditions like myself, type 1 diabetes, and some speakers on the panel, the crisis can be even more devastating, and the voices of those in need are more in need to be heard than ever. Tonight, we're so privileged to hear from three accomplished change makers whose work embodies the personal and professional dedication to advocacy in demanding circumstances. I'm joined by Dr. Sana Ajmal, a global diabetes advocate and the visionary founder of Miti Zindagi, and our collaborators for this webinar today, which is a nonprofit that leads efforts in Pakistan to support people with diabetes, championing access to care and community empowerment. I'm also joined by Dr. Amani Al-Bayraktar, who's a renowned researcher and educator in nursing and brings deep insight into the psychological and technological dimensions of chronic illness and management. Her work on stigma, innovative care solutions, and health equity underscores the importance of holistic support, especially for those displaced or impacted by conflict or disaster. And last but not least, Dr. Mohammed Siam, a Palestinian doctor and global health advocate who draws on a wealth of frontline experience in crisis and responses. With a background in healthcare management and firsthand knowledge living with diabetes himself, Dr. Siam works relentlessly to strengthen care systems for marginalized populations. Throughout this discussion, we will explore the pressing questions, including understanding the realities and unique challenges of the people living with diabetes in conflict zones like Gaza, or those affected by the recent monsoon floods in Pakistan, or those stigmatized or marginalized. We will explore the role of NGOs in ensuring the delivery of life-saving medication and the need for education and policies to protect them. And our goal is not just to share experiences, but to really shed a light on these important issues from those on the ground, and whether you're a health practitioner, policymaker, a patient, or an ally, to gather your voice, and together we can champion the change where it is needed most. Now, with that, I'd like to start with Dr. Sana Ajmal. From your experience and the work that you do with the Miti Zindagi Foundation, I would like you to share what are some practical strategies that you've used to ensure the continuity of diabetes supplies during humanitarian emergencies, for example, the recent floods in Pakistan, and how we can adapt these in other crises and emergencies globally.
Thank you so much, Sylvie, and thank you to DiaLeb for organizing this webinar with us. I think this is such a hugely important topic, as you also mentioned in the introduction. It seems to be getting more and more and more, aggressive as well as pervasive in our region specifically and around the globe. Preparedness is very important. I can't stress it more, but preparedness is very important. But no matter how prepared you are, how well prepared you are, there are always challenges on the ground to overcome. So two of the most important strategies we used during there were floods in Pakistan in 2022, and there are floods again now in Pakistan happening at the moment. In 2022, I think the two most important strategies we used, one of them was engaging the community. I now very strongly believe, I used to believe this, and my belief in this has strengthened, is that the community is the most resilient, the most available, and the most sustainable resource you can have, specifically in case of emergencies. Not only are they willing to help, they also volunteer as long as their costs are met and as long as they are also being supported in emergencies like this. So in 2022, even before we could engage any relief organizations on the ground, it was the community that came forward. Relief organizations, especially large relief organizations, have competing priorities such as food, clean water, infectious disease, etc., etc. And type 1 diabetes specifically, or insulin, is not even on their radar anywhere. There's a lack of understanding that food is as important to a type 1 as insulin, if not more. I mean, it's like you can't just give them food without giving them insulin. So this was an issue because in 2022 we were not that well prepared for this whole situation. So we went from organization to organization asking them, but they were so overwhelmed by the magnitude of the floods and the work they had to do that just listening to the smaller numbers of people who needed insulin, they would not prioritize that. And because there was so much work to do that, I mean, it wasn't their fault as well. But the first line of action that we had after people were being shifted to safer places was to get the community activated. People in those areas, people with type 1 whom we knew, they took insulin on boats. They carried it on foot. They went from village to village asking if anyone needed insulin. They got announcements done in mosques and community centers, and so on. So it was actually the community that responded to it before any relief organization came forward to help us with the distribution and all that outreach. The other important aspect, it stems from the first one, is that we had connections with the community members from the affected areas, and some of them needed support themselves. So it was easiest to support people where we had this network and where we had the data. A known community network that reaches out to people living with the condition in a certain area is very important. It is a very important hub of data as well as of information. So you can plan your resources, you can plan the activities, you can engage them as volunteers, and also relay information through those networks. I truly believe that community networks should become a vital part of preparedness, along with other aspects such as having stockpiles of insulin to use in emergency cases, etc. This also motivates people to share what they have in the very beginning. And right now, this is happening right now in our network, is that there are people who are stuck in floods, in these flash floods. And people within the community network are asking for support, and the network is responding to it in an organic way. I think this very concept of building community networks on grounds should be a very important part of preparedness.
That's so spot on. And you're reminding me of how we started the Medication for All campaign. It was pretty much our own network of patients who came forth and started telling us their needs, but also started telling us the needs of their neighbors, their friends, what they had found out. So it's that peer-to-peer connection which enabled us to then allocate more efficiently the resources where required. So that is so spot on. And I think I want to go to our next speaker, if I may, Dr. Muhammad. Nowhere is this more necessary and more apparent than the community that's happening in the experiences in Palestine and the ongoing conflict in Gaza, where you cannot have external support, as you know, which has been blocked off from relief organizations entering. So this concept of community is so critical. And from your experience, what are the most urgent systemic gaps that are being faced in terms of diabetes care during this horrific conflict? You're still on mute.
Sorry, I'm still muted. Yeah, once again, thank you very, very much for having me. And yeah, I cannot emphasize more in what you, Sylvie, said and what Sana said earlier about community engagement and about the role of the community and everything that we do. But as you mentioned, sometimes the safety of the community is at risk, that that people of the community, members of the community, are not able to provide care, are not able to talk, are not able to provide peer support, are not able to share resources with each other. Because of what's going on the ground, because of how horrific the scenes and the conflict itself is. But when we talk about systematic gaps, I always like to think about it like from let's say from top to bottom as under an umbrella of health system itself, because again, Dr. Sana mentioned preparedness, and I got into the field learning from Slim Slama, our dear friend Slim, who always said, "What you prepare for is what you will get during an emergency." So we do need preparedness. We do need coordination. We do need uh, health systems themselves, governance of the health system to be on point, to coordinate. We do need diabetes itself to be included and integrated into health emergency planning, response, to be part of the health cluster, to make sure that we prioritize diabetes and other non-communicable diseases. Because in many conflicts, in many humanitarian settings around the world, we do notice that it is not prioritized. Whether when it comes to leadership roles, whether when it comes to financing stuff, and even the community, even if the community wants to speak, or people of the community want to speak, they're usually faced with many challenges that you'd feel that they're shut down from speaking. And ever ever since we started advocating for diabetes in humanitarian settings, we keep we title, let's say, people with diabetes as silent victims of wars and silent victims of humanitarian settings, because they're under prioritized, they're not talked about enough. And let's kind of face it with complete honesty. The needs of people with diabetes in humanitarian settings do not differ from the needs of people with diabetes in peaceful times. Needs do not differ. The needs are always the same. People need supplies, people need services, people need support, people need education. You need to know how to access these supplies. We need to know how to provide these supplies. And it's always again about how can we mitigate the challenges that we face on a systematic level and coordinate amongst ourselves as providers and as organizers of health system responses. A big issue that we've noticed in Gaza and many other places as well is that services are usually fragmented, because when the health system is weakened because of the crisis, when services are disrupted, a lot of international actors would come in to, let's say, fill the gaps of the services. And unfortunately, the fragmentation of services confuses people with diabetes. Numerous people with diabetes that I am in contact with from Gaza are mentioning how guidelines sometimes are conflicting. The advice that they receive from a doctor in working in this clinic is completely different to the advice that they receive from a different doctor in a different clinic. And our inability to unite our voice or ability to provide the services, unified services for people with diabetes, makes it completely difficult for people with diabetes to manage themselves. And again, when we mention supplies, we always mention supply chains. And an important message that I would like to say is that it is always important to depoliticize health, because access to, in our case, insulin and in general medications is a human right. And if it is available and it's politics that is stopping it from reaching to the people in need, then that is a big problem that we need to advocate for, that we need to work for, that we need to find solutions for, and keep pushing on policymakers and stakeholders to change this. Unfortunately, sometimes this is harder than we think. We've tried numerous options and opportunities in Gaza to be able to kind of do something for people with diabetes there. There are a lot of providers who are actually doing their very best to at least get the very minimum of supplies to people, provide them with the very minimal services and education. But again, it's the politics that sometimes gets into the way. Um, I would also say that probably the last thing that we've noticed, or we notice in general, that diabetes should not be treated in silos. We need to integrate diabetes and in general and non-communicable diseases into our, let's say, community health level or primary healthcare level of responses. So we'd be able to actually get to the people at their level. People might not be able to get to hospitals. We don't have the resources or the supplies in hospitals. Hospitals are overwhelmed with trauma cases in humanitarian settings or whatever the situation is going is offering for those hospitals. So it would be also very, very important that we reach to people, that we get to people, that we learn from people, that we listen to the voices of the people themselves, so we can further understand their exact needs and deliver based on their needs instead of delivering based on whatever we think are their needs are. In Gaza and in many low income settings and low and middle income settings, we lack data, we lack information, and this makes it also extremely hard for policymakers or for international organizations, for the health system itself, for the local health system itself to respond, because we don't know numbers, we don't know the exact needs, which definitely makes it very, very hard and tough to respond to the needs of the community. Um, yeah, I
Definitely.
think in general, yeah, those are some of the gaps that we can think about from a systematic level to the community level. But yeah, the message is always is one. The needs do not change in a humanitarian crisis. We need to prepare to prioritize and ensure that we listen to the community.
That is very, very insightful. And it's a reality that we face in terms of the segmentation and fragmentation of healthcare, even without crisis. We still haven't solved it the way that we should. So it only gets protracted and amplified when there is, as you say, humanitarian needs and other priorities take precedent. And you mentioned the psychological burden on the victims, and you called them the silent victims of crises. And I want to transition to our third panelist for today. Dr. Amani, your research has explored the psychological and psychosocial impacts of chronic illness like diabetes. And with the crises that we are experiencing, what mental health challenges do displaced or conflict affected patients of diabetes living with diabetes face? And how can we adapt care models to address these issues?
Yes, thank you so much, Sylvie, for your for inviting me to this very important webinar and discussion. And thank you for this question, which is a very, very important question. And as a healthcare researcher myself, focusing on psychosocial aspects, I really appreciate including psychosocial and psychological and mental well-being into the care of people living with non-communicable diseases such as diabetes. And just I'm going to talk a little bit about the context, my context. So I'm of Lebanese origin. I lived in Lebanon until recently. 3 years ago, I moved to Scotland. So I will be sharing some information about the Lebanese context in my answers. So you've mentioned earlier the effect that or the continuous crisis that Lebanon has been going through since I think 2019, the last 6 years till now. The blast, the economic crisis, the COVID, and the war that happened last year, and this really takes a deep toll on the psychological well-being of people living with diabetes. And it's really not just about disrupted access to medicine. It's just about living for years in an environment where their stressors are constant. It's living is unpredictable, and it's becomes really very much overwhelming. So a study that I've done in 2020 among young people living with type 1 diabetes showed that 4 in 5 young people living with type 1 diabetes, they experience moderate to severe diabetes distress. And this is something that is very higher than numbers that we found in other places in the world. And this emotional strain, it links to poor self practices and less frequent monitoring and basically less poorer health outcomes. And it's not only in type 1 diabetes. Studies have been done in people with type 2 diabetes. They they feel hopelessness, they are fearful about their ability to continue treatment, and this often leads them to feel disengaged from managing their diabetes. So for many, the mental strain is triggered not just by health concerns, it's by the daily struggles where every blood test, every insulin injection, every clinic visit is exhausting, and it's a battle to do. And this issue is very much compounded in people with low-income communities and people where we have displaced communities. For example, we have Syrian camps, we have Palestinian camps, we have Lebanese camps. During the war, a third of Lebanon, the south, was moved. They were displaced, and they lived in schools. They lived in areas that they had very disrupted care provided to them. So we had uncertainty about aid continuity. We had so many, and this does not only impact their physical health, it also impact their mental health as well. And Dr. Muhammad will keep me right, because stress affects also glucose levels. So stress hormones, they affect glucose control. They, combine this with disrupted sleep, combine this with irregular eating, combine this with reduced physical activity, and it becomes like a vicious cycle where you have poor diabetes levels, and then you have further stress. So breaking this cycle, it really requires not just focusing on medicines, but also embedding mental health and psychosocial support into every level of diabetes care. And there has been some initiatives, and I'm going to talk about the NGO initiatives that organizations like DiaLeb has taken part of, where they provided not only medicines for all, this very important initiative, but they provided peer support groups and social support to people living with diabetes. There are also other organizations like Positive on Glucose, where they also did some peer support groups where people with diabetes, they met regularly. They discussed challenges, they shared coping strategies, and they really led to reducing isolation, this feeling of isolation, like I'm living in this alone, and it really provided emotional resilience. And that has been proven to, through research, to be highly effective in the overall health of people living with diabetes. So basically, to answer your questions, care models should be adjusted to include also mental health as part of the treatment of people living with non-communicable diseases, and diabetes is a big part of it. And you would see some international bodies applying this, such as WHO. We have the UN High Commissioner for Refugees. They include mental health and mental well-being as part of their care bundles. But I think this should be more focused on, because at the end of the day, in crisis, you would focus more on providing insulin to a patient living with diabetes, and not so much on asking them how you're feeling. But I think this mentality, we can also try to change it bit by bit.
Definitely. And thank you so much for that point. As you very well mentioned, and thank you for highlighting the programs. The patient advocacy element and the community and peer support groups cannot be underestimated. The power that it has to really support people living with diabetes and other non-communicable diseases is really, really something that has to be integrated throughout. And it goes back to the point that Dr. Muhammad had mentioned as well about the integrated care models. When we talk integrated, we mean holistic integrated care models, looking at all the different aspects of the patient. So with that in mind, I want to go back to Sana and the work that you do, and I want to bring back this element of community, but also the role that the grassroots advocacy and NGOs like yours, like DiaLeb and others, factors that we play when it comes to influencing national diabetes policies, particularly when we're looking at crisis-prone regions, because it's a hard balance between the immediate relief when there is a crisis, but also ensuring you have all been talking about, this long-term care and going beyond just the immediate relief needs. So what are some strategies, what are some experiences that you've had in your advocacy efforts to promote the care required for patients with diabetes, people with diabetes?
Thank you, Sylvie, and thank you, Mohammed and Dr. Mani for the inputs. And I would like to, bring in some of the aspects that both of them have shared. And I'll start with echoing Mohammed. There are timelines for using any strategy, and of course, you can't. The peer support group, even if whether it's for when it's for used for access to care, it can only be utilized for as much as a few weeks to maybe a month. That's the max that any peer support group can afford to have for something as long term as Gaza has, proved to be. This is just a strategy that can be used in case of natural disasters, where you know that the first few months after this is going to end, or where there are wars that are hopefully ending soon, or there are chances of a ceasefire. So, having said that, it's still a very important part of that initial preparedness and initial strategy. And the same peer support group provides emotional support, mental well-being in the long term as well as in the short term. So, the first responders in terms of access is, in my opinion, are peer support groups or community networks, as we call them. But systemic response has to initiate afterwards, and any government has to look into these issues which are being faced in our countries due to climate change or war or conflict, anything. To how do we actually initiate that systemic response to any disaster later on? And that requires effective policy making. And you can't make any effective policy, and I'll again echo Mohammed, without actually involving the people on the ground. What do they face? What do they need? How do they fare in when such things happens? For example, I'll tell you one of the data that we collected. We started collecting, and we've now reached a conclusion where we found out that there were lots of switching in terms of insulin, even with the same genre, like using human insulin from one brand, switching to another, or changing the delivery device, has affected people's HbA1cs, and quite a lot, more than 1%. The second thing we found out that even after reversing that to the first initial insulin, the HbA1c response was still affected. So there has to be policy making by looking at these. At times, when we're sitting in silos, when we're sitting in offices, policymakers are, making policies that suit that are right for the economic reasons, or that are right for a response reason, and miss out these very important aspects that people on ground face. That leads to policies that are ineffective, or that leads to policies that may be missing out from capturing the cascaded effect that they will have on the community. So I feel like that it's very important to balance out the immediate response with the long-term care, and in my opinion, the best placed people to carry out an immediate response are the ones who are actually providing the long-term care as well, because they know the person or the persons they're providing care to best, and they're the ones who can actually respond to their needs in a more effective way as compared to as compared to any relief organization that comes in and goes away.
Great. And thank you so much for that point about involving the people. I think far too often policies are made in a vacuum outside of understanding the realities of the ground. And I think, Dr. Mani mentioned this, there have been some more consultations and some changes in policies with including patients with lived diabetes experience in some policy making, but I think we need to see a lot more of that to ensure that the policies are truly reflective of the needs of the people on the ground. And I want to go back to this issue of the long-term needs and the holistic integrated care. And I want to go back to Muhammad. You are someone who's living with diabetes, but you're also a healthcare professional. So I believe you have an interesting perspective on patient-centered care and some lessons and experience that you can share with the community and our listeners for maybe medical professionals when treating people living with diabetes, or for what care relief providers can do when they're encountering people living with diabetes in crisis and humanitarian settings.
Yeah, well, I think the first thing that I would like to say is, again, echoing what Sana and Amani just mentioned, like, listen to people themselves. Um, People during crises are stressed. They're facing the duality of living the crisis itself, same as anybody else, but also living through their own crisis, the burden of living with a chronic condition during a crisis, the fear that I might not have enough insulin to survive till the end of the week, the fear that I have to ration my insulin because I don't have enough insulin, or I have to switch between types of insulin. I know people in Gaza who switch between 6 different types of insulin in 2 weeks. It was insane. People who are blindly managing their diabetes because they don't have test strips, people who again whom are starved, they don't have food, they don't know how to treat their lows, and a lot of organizations were trying to find solutions or mitigation plans to tackle hypoglycemia episodes, but nothing is on the ground that you'd be able to tackle the episodes with. So we're dealing with an overwhelmed, distracted healthcare system in a humanitarian crisis. We're dealing with healthcare professionals themselves who will be overwhelmed and tired and unable to provide services. A lot of trauma cases potentially. People with diabetes, again, with the problems about access, about their ability to get supplies, and all of these things. So the first message would always be, again, listen to the needs of the people, listen to them, what exactly are their needs, and try as much as you can to provide according to their needs, not according to what a donor potentially can give you. That's a big problem. And when we design care for people with diabetes and crises, we need to design care for continuity, for sustainability as much as we can. We need to plan based on what people already had before the crisis, and plan for something to make sure that we continue that during the crisis and beyond the crisis, and make sure that try to enhance it even during or after the crisis. In crises, it's a big issue sometimes that people focus a lot on perfection of how services could be provided, and we write a lot on papers and we have a lot of meetings, but at the end of the day, those do not translate into actual actions that help people with diabetes on the ground, and that is a big issue. The quality of life, again, and this is probably Dr. Amani can talk more about this. The quality of life of people with diabetes is severely affected during a crisis, and um, trying to serve this part of the community, or this portion of the community, not in silos, but while integrating it in with mental health services, with psychological support, with anything else that they potentially might need during a crisis would be important, and this needs to be incorporated in health models, in response models, in guidelines that we use. We need from health professionals, from policymakers, to make sure that they coordinate the responses. We need to make sure that diabetes and NCDs are part of the health cluster planning. It's part of something that we report to each other too. We need to make sure that the community or people from the community have the voice in that setting, in the planning for the care that we want to provide for them. And a message for health providers and policymakers or international organizations with diabetes or chronic conditions in general. There are a lot of predictable outcomes that you can predict, whether positive or negative. And it is important to tackle based on those predictable items or predictable outcomes. You know what's going to happen for a person with type 1 diabetes without insulin. So I need to work on providing them with the insulin that they need. I know that if people are blindly managing their diabetes, they're going to end up with acute complications and potentially chronic complications. So how can I tackle this? Just think about the predictables of the care that you're providing, that you're trying to provide for people, and work based on that. And again, for the diabetes community itself, keep talking. Your voice is very important. It matters. It shifts the way we think about tackling and managing diabetes in crises. And at the same time, for people in the diabetes community, in the global diabetes community, we can always support those on the ground in different and in various ways, through advocacy, through supporting, through education, through just sharing experiences, being by their side, and also pushing harder on policymakers and decision makers uh, uh, to alleviate the burden that people with diabetes are going through. So it's kind of again, things that we can go through the humanitarian cycle in general, and take point by point. How do we prepare? How do we reduce the risk? How do we respond? How do we recover? But in general, we know what's predictable. We know what we can do. We know the importance of the voices of the community, and we need to act based on that.
Definitely. And it's interesting because a lot of times there is a stigma that comes associated with people living with diabetes, and that stigma only tends to be intensified in these times of crises, right? Because the burden becomes even that much burdensome to caregivers, to the needs of the community that's suffering. And I wanted to go to Dr. Amani and to just ask, from your research and the work that you've done, what are some approaches that you found effective in helping reducing the stigma and promoting the equity in diabetes care, particularly among some displaced populations, like you mentioned, with the work you've done on the field in Lebanon?
Yeah, thank you, Sylvie, for this question. It's diabetes stigma is a very tricky subject. It has become a growing concern during the last few years because of its real impact on people living with the condition, and diabetes stigma is more or less has to do with misunderstandings and negative stereotypes that is associated or linked to diabetes, and it's always caused by people think that diabetes is always caused by poor lifestyle choices or unhealthy eating, and it leads to blame, it leads to judgment, it leads to stereotyping, and it can have so many effects, and it is experienced very widely. It can be just like people being told not to take insulin. If you're type 1 diabetic, they might tell you, oh, don't take insulin, you're just harming yourself, just don't eat sugar anymore, and or exercise. So these to other extremes where you get kicked out of your job because you have diabetes, or in especially in sometimes in some cultural areas, you have really poor chances of getting married if you have, for example, diabetes. So it's really very wide, the feelings, the effect, the stigmatization around diabetes. So we do know a lot about stigma in diabetes, and we do know, that talking from a researcher background, we do know that stigma affects people living with diabetes. It affects their self-care practices. They become isolated. They don't take care of themselves. They might not take insulin in public because of these stigmatization against them, and this affects them physically, but it also affects them psychologically, and it has been proven through research. And this is exaggerated when we are living in in, for example, third world countries or overcrowded areas or places where we have very low awareness about, healthcare about awareness or health literacy, for example. So even though we do know that stigma is there, even though we do know that stigma affects people negatively, we have very little research on how to decrease it. We do know how to decrease it in principle. So we do know that, for example, public education is important. Awareness can help, challenge the myths about diabetes. It could start from schools. It could move to wider communities. We can have broader advocacy. We can have awareness campaigns. We can help, shift social attitudes. But we do have little information about anybody who actually applied these interventions and did we find any effect of it. So I think it's because it's a recent concept that has been going on, so now we know in principle how to decrease it, but we haven't seen any actual data on the ground. I always talk from a researcher perspective. I don't have any evidence in front of me. I can tell you how to decrease it, but I can't tell you through evidence. But I think some of the interventions that has been done perhaps is embedding diabetes care, and I'm talking here about areas in crisis, when we embed diabetes care into routine NCD or primary care. So we don't highlight caring for people. We don't single patients out that they have diabetes. Sometimes that would be a good way to do it. As we said, we provide education, we provide awareness campaigns, peer support, family support, family inclusive sessions, and this is very, very important. And I think it reduces the shame and it builds confidence. But I think, talking from Dr. Muhammad's point, like how as healthcare professionals, we care for people and provide person-centered care. It's amazing how a lot of stigmatization happens from healthcare professionals towards people living with diabetes. And this is something that we should start by ourselves, by the healthcare professionals, training providers to use empathetic, non-blaming language, and provide this provider-driven stigma that several people living with diabetes, they actually complain from. So my takeaway messages is, stigma is reduced when diabetes care is normalized, and we provide empathetic care through for peers and families, and including healthcare professionals in that.
Yes, this is great. And we have a question on the group that I just wanted to highlight because it's very linked to the discussion that we had earlier. And it's a question from D1FY, which is a startup type 1 diabetes community for youth and young adult in Uganda in sub-Saharan Africa. And Ivan is asking how we can ensure the real inclusion of people living with diabetes in the initiatives and not just performative acts. And I think what you've mentioned, Dr. Mani, is spot on. I mean, we have some interventions, but you don't have the data yet. So much more research is required, much more interventions. And we have to analyze how the impacts of those interventions are so that we can apply them globally, I guess. And Dr. Muhammad was mentioning, listen to the people. How can we listen to the people more? And I will open it to to all of you. What are some strategies that WHO or other care organizations can apply, and how can grassroots NGOs like this one in sub-Saharan Africa be helpful in ensuring the real inclusion of people living with diabetes?
If I may, I think the first thing that we need to look at before answering this question is the journey of diabetes advocacy throughout the years. Where were we 10 years ago in diabetes advocacy and in including people with diabetes in decision making, and where we are right now, and the improvements that we've made so far? We're definitely barely scratching or touching the surface yet, and there's a lot to be done. And potentially, let's say again, same answer. We talk a lot about inclusion, we talk a lot about advocacy, but we don't have practical techniques or steps to how to do it because we're still exploring the field. Now, whatever you feel like as an advocate or as an organization that supports people with diabetes, and Sana, you can reflect on this. Whatever you feel is enough. Whatever you feel, again, because it's all about meeting people's needs. Um, so whatever you feel like you've done enough or you've actually met people's needs, then you've reached the point where this is real inclusion in your initiatives and in national initiatives and global initiatives. Sylvie, you've mentioned WHO in the Global Coordination Mechanism Forum within WHO. Meaningful involvement or meaningful engagement of people with NCDs and mental health or mental conditions is a big thing. It's something that WHO is working on through webinars, through people inviting people to talk, inviting people to write, inviting people to speak. Do whatever you feel like is presentative, let's say, of yourself and of your nature. Get people with living with different chronic conditions together to brainstorm, to think, and all of these are important points to ensure that we progress in how we include people with diabetes and other non-communicable diseases to the discussion table. We're slowly, again, while scratching the surface, getting people with diabetes and people in the global diabetes community to get into policy making, to not only be included and have a seat at the table, but for them themselves to lead those tables, to lead those discussions based on their experiences as people with diabetes, as health professionals, as global health managers, are in their own capacities. Because when you think about chronic conditions again, and every family around the world is affected by a chronic condition, people need to understand how deeply rooted chronic conditions are in our lives and in the lives of the people that we love and the people that we care about. And when we understand that, we will take more emotional steps. And of course, statistics is needed, research is needed, data is needed, but also the human part, the emotional part of how we include people with diabetes and include their fears and our understanding of the fears of our loved ones and the people that we care about makes it, of course, all of this all together makes it again, let's say, enhances the chances and makes including people with lived experience in a meaningful way something not only that we dream about, but something that we're already doing. We might have been dreaming about it 15 years ago, but things are definitely changing now, and yeah, things are pretty
Yes,
much progressing.
that is an excellent point. And there has been a lot more inclusion we see of people with lived experiences in these forums, which is really already a great move. And I want to bring back Dr. Sana from your work with Miti Zandagi. How any contributions that you have seen and any experiences that you have seen meaningful in the inclusion of people with lived experience?
Well, thank you so much. I would like to echo Muhammad when he mentioned this, that so I'm a storytelling person and I always look at the real lived experience for people with diabetes. But this does not mean that data is not important, as Dr. Amani is saying. But when there is no data, like in our countries, you can only advocate with the storytelling aspect. You can only advocate with the human aspect. So we faced this when we started Meet Zindagi. We started as an advocacy organization, and we faced this all the time. That whenever we were trying to speak up, have a voice, there would be questions about where's the data, how do you showcase that? So we took it upon ourselves to showcase what we show the change, be the change that we wanted to see. So Meet Zindagi started an insulin support program, which was designed by people who actually needed that support. And now, last year and this year the program was rolled out, that exact program design was taken up by our provincial government in Punjab to initiate an insulin support program in the province. That's the power of advocacy. Sometimes you have to create something, pilot it, to showcase, collect data, and then advocate. Another thing that I always, keep repeating, specifically in front of our peer leaders who lead our peer support groups, is that if we don't have a seat at the table, we bring our own seat. So we have been making noise on media, on social media, on writing to newspapers, etc. We showcase these stories because, policymakers are, at the end of the day, they're also part of the society. They're also human beings who are reading all those things. And when they read those things, somewhere it affects them. And somewhere they keep it in their mind. And it is slow. Advocacy is slow. The change is slow. And tokenism is real. But at the same time, as Mohammed said, things are changing. And we are also seeing appreciation of lived experience inclusion in decision making, even if not as much as we would want to see, but that change is there, and hopefully it will continue to be the way we want it to be.
So to your point about the need for data and that link with storytelling, I want to go back to Dr. Amani. Stories are so important, and sometimes they drive the understanding of the gaps that exist in the research to create the data. But you've also done some work on technology and digital tools. And what are some of these from your research that could be used to help support that data-driven approach, particularly in times of crisis?
Yeah, so when we talk about digital healthcare or digital health technologies, I just want to also bring the attention to one point, which is the availability and access to healthcare technology or diabetes technology in specific during the time of crisis. So as I mentioned earlier, in Lebanon during the crisis, we had very limited access to supplies, and we had very limited access to diabetes medication. And so we had people like Dr. Mohammed was saying, we had people who weren't able to test their blood sugar levels because they didn't have any machines or any strips. We had people who were using flash or continuous glucose monitoring devices or insulin pumps who had to go back to using insulin injections because they couldn't get the supplies because of the high prices, and they weren't available. So using healthcare technology is an very important factor, talking about data and talking about evidence. Evidence shows that using these kinds of technologies very much affect the health of people living with diabetes, because it improves their blood glucose levels, it improves their self-care practices, and it really improves their mental well-being. It decreases stress, it decreases anxiety, and it decreases the burden of living with diabetes. So I know it's a bit of an outreach, but I think that including these supplies as part of the aid bundles in times of crisis is not something that we should, is something that we should really consider as well. It's not only, supplying insulin, but including these technologies I think is important. Now, the other aspect of digital health is having, the remote digital health, which is, like telehealth or telecare, which is something that is very, very relevant when we have areas of crisis. For example, in Pakistan now with floods, of course, people will not be able to access, healthcare clinics, and when we have displacement, it's really disrupts access to stable clinics. So digital interventions, they really are mean to extend the continuity of care between visits, and there are evidence that works with, so for example, SMS-based reminders for appointments, for medication taking, they work. Call center telehealth, and there's an initiative in Lebanon done by Doctors Beyond Borders, where they piloted a diabetes digital therapeutic, intervention in a remote area in Lebanon, which is Arsal wal Hermel. They co-created, which is something that we were talking about, co-creation of such devices with the patients. They focused on things that are important to them, like medication adherence, glucose monitoring, mental well-being. But when I was reading about that project, it turned out that this happened, and just later the war happened, so they didn't have access to internet, and they didn't have access to electricity. So this also echoes Dr. Muhammad's point, where we need to have something that is sustainable. So I can't just develop something that doesn't work in case of crisis, or in case of extended crisis. So reforming it into something that we can adapt and we can use, and these digital health interventions, they actually are means to prevent the fragmentation of care that also Dr. Muhammad was talking about. And it's also an important factor. But an important factor is how to do it in an ethical way, and how to preserve, the data privacy. And these are all things that we need to be considering very well when we are developing these kinds of technologies.
Definitely. And there's so much that can be gained from all this innovation, but it has to be done in an ethical way with the right policies and protections in place for everybody. I'm realizing it's been such an engaging discussion, and we're very close to the hour. So I wanted to give it, I guess, a minute for closing remarks from our panelists. So maybe Dr. Muhammad, you want to give us some closing reactions?
Yeah, well, I believe the message is clear. I didn't want to I unmuted myself, not because of the closing remarks, but just to comment, if possible, on the MSF point, the Doctors Without Borders point in Lebanon. One good thing that they've done is that because of what happened, they were trying to be proactive in solving the problem and connect with patients in different ways and provide patients with different digital health solutions to manage their condition, to manage their diabetes, which is also very crucial in the way we manage policies and lead on policies to manage diabetes in humanitarian settings, being proactive in the way we do it, listening to the community and including the community in the discussions that we make and in planning the services that we provide for them. I think the last thing I would like to say is, again, when it comes to policies, it's very important to coordinate, prepare very well, because what you prepare for is what you will get. The needs for people with diabetes are not going to change with a crisis, so we need to understand the predictable outcomes and the predictable variables in the management of diabetes, and act based on that, and ensure, of course, that the voices of the community are included in our discussions and in planning and responding and in recovering from a crisis. It's also important to prioritize diabetes and NCDs and integrate diabetes and NCDs in the architecture in emergency architecture to make sure that we respond to the needs of the people, and that we meet the people where they are, instead of tackling issues about an overwhelmed fragmented health system. That's probably the message that I'll provide. I know I talk a lot. I'm very talkative sometimes, but thank you very much for having
It's very
me.
clear and very well received. Thank you so much, Dr. Sana.
Thank you so much. I think I would like to give a message of unity here, and I think that we all need to depoliticize humanitarian crisis, specifically when it comes to access to healthcare, as mentioned by Muhammad earlier as well. We really need to unite and dig deeper into what we can do together. How can we advocate together on a regional and a global basis, both to make sure that we are prepared as well as able to actually swiftly act in case of any crisis. And I think I do feel that at least the diabetes community and the advocates community that I talk to, they're very united in this respect. So yes, I think my message would be that we really need to look deeper into this in a very united way and after depoliticizing the topic altogether.
Excellent. Thank you. And Dr. Amani, please.
Yes, finally, I would like to end by saying that I think the main point is keep on including the voices of people with lived experiences in all aspects of diabetes, whether policy making, whether in diabetes organizations, whether in research. So now we don't do any research without having a person with lived experience as part of the designing part of the team, of the research team. Keep advocating for people with diabetes, and again, more focus on the psychological well-being that is often misrepresented.
Thank you so much. Really, this has been a brilliant and very engaging discussion, and your insights have been so amazing and inspiring. And just to finish off, I think what this has shown is that we need more of these forums. We need to talk about this topic more. We need to engage and collaborate more across patient-centric organizations, but also with the policymakers and the healthcare providers, like the doctors on this call, and health practitioners. And to those asking, how do we make this more apparent? How do we keep the topic going? I urge you to do the same, to engage in discussion, to reach out to your community. Community and patient empowerment is key, including people with lived diabetes experience in policymaking is key. Prioritizing healthcare and universal healthcare, depoliticizing health in times of crises, and remembering the holistic and integrated care and the needs of people with diabetes, not just from a medical perspective, but from the community holistic well-being and mental health perspective is also key. I want to thank you for everything that you are all doing in your respective fields, in your countries. I want to thank our listeners and participants, and good night, good evening, good morning, wherever you are. Thank you so much.
Thank you. Thank you.
Thank you very much.
Thank you, Sylvie. Thank you, DiaLeb-The,
for co-organizing this. Thank you very, very much.
Bye-bye.
Bye, everyone. Thank you so much.